Good afternoon, everyone. Well, to all the honorable delegates who are here, all the friends and the colleagues, to my family, thank you very much. I'm deeply, deeply honored to receive the Dr. Lee Jong-wook Award, the Memorial Prize for Public Health. It is something when you walk through a career, you don't have an ambition at the end to say, I think I'll get a prize. But when you get it, it's actually wonderful. I'd like to say thank you very much to the Geneva Health Forum for hosting this, and to Kofi, thank you very much for your for considering me for this award, but also for your warm introduction. I'd also like to say thank you to the Minister for his kind words, and to Soraya from WHO, and Precious Matsotso, who you heard, who has just chaired, as you heard, co-chaired the pandemic agreement. You might just, I'll say in brackets for Precious, she is a good friend of mine. So you have to take a pinch of salt with some of the nice things that she said. So in terms of this lecture, I decided to talk about activism and research and evidence in public health. And the reason for doing that is that I think for many of you who are involved in public health, you will know that we have to have research and we have to have evidence. But many people will argue that actually to be in public health, you also have to be an activist in some shape or form. This was what I was asked to do. The laureate speech should highlight your achievements in public health, particularly in the area of infectious diseases. I would rather give a scientific plenary than write this. This has caused me sleepless nights. It's very difficult to look back on your career and write something that covers the whole ambit of what you've done with a focus on infectious diseases, but also in a focus on activism. So I hope I capture this for all of you. I went back to this definition of health, and this is from the World Health Organization in 1946. You're all familiar with it, but it's worth looking at it again because I think it was prophetic. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. That is a profound definition and goes much more, it goes way beyond individual patient health. I then looked up health activism, and that's a newer concept, so I went to AI. Health activism aims to create more equitable and supportive environments for individuals and communities to achieve optimal health. This can involve a wide range of actions, from direct service to advocating for policy changes by challenging power structures and systems that negatively impact health and health promotion. So I went back and I thought about what had influenced my career and my life, and I went back to the book Outliers by Malcolm Gladwell, which I'm sure many of you have read, and came up with some quotes. And the first one was, it makes a difference where and when we grew up. And if I said this to everyone in the room, you would agree with this if you looked at your own careers and your own lives. So the picture on the right-hand side at the bottom, my parents, my sister, who's here, and I understand many of you have been congratulating her for getting the award today. It's me, not her. But the influence here was that my father came from the Welsh coal mining valleys. His father was a coal miner and his grandfather was a trade unionist. So through him we had a sense of social justice and a belief in organized labor, but also a sense of what it means to come out from poverty. My mother came from a Welsh rural area, a father who was a preacher, a Methodist preacher, but also a headmaster. So a very strong belief in education. And from the two of them, they framed a belief in education and a desire from my mother to go into medicine. Then the next quote from Malcolm Gladwell is that we are all beneficiaries of some kind of unusual opportunities. You think back, you'll recognize this. So I did go into medical school in Cambridge, and this was in the 70s. At the beginning, there was a very strong belief in women's liberation movement that was going on there, and this was a protest. Well, it was in support of women's rights. In those days, you had to go to London to do your clinical training, and there I got involved with a movement for homeless people to stop the demolition of Victorian houses so that homeless families could actually get occupation. Also at the time, in the 60s and the 70s, was the anti-apartheid movement. There was a Springbok tour to the UK, and there was a lot of protest there, and I became also involved in the anti-apartheid movement. I did manage to finish my degree, however, and also did a master's thesis in social and political science. And this was the first time that I focused on really a health question, which was looking at maternal and neonatal outcomes after induction of labour. But then, opportunity. I went to do my student elective in a small Welsh mining village called Glencorrwg. Some of you will have heard of Dr. Julian Tudor Hart. He was a man ahead of his time. He was a GP in the small village, but he also undertook research. And his belief is beautifully summed up here. Medical services are not the main determinant of mortality or morbidity. These depend most upon standards of nutrition, housing, the working environment and education, and the presence or absence of war. And never could that be more true than today in terms of what we're seeing in terms of conflict. He wrote a really incredibly important paper right back in the Lancet, but in 1971, and it was called the Inverse Care Law. And what he argued was, and he saw in the village where he worked, was that the socially disadvantaged populations receive less health care than socially advantaged populations. And if you look at the dotted line at the top, that is need. And you look at the solid line at the bottom, that's the availability of resources and health services. And the people with the greatest need often get the least resources. The third thing I'm going to quote from Malcolm Gladwell is something he calls lucky breaks. Now, you might recognize this person afterwards. This is my husband, Faisal. And the reason I'm highlighting him is because I met him, and I remember I was very involved also with anti-apartheid thinking. He was from South Africa. He had come to the UK to do his medical training. And meeting him meant that my direction in life then changed to Southern Africa. He and I went to Zimbabwe, and immediately after independence, where I was a pediatrician in Harare Central Hospital. What we saw there was the inequality that had been inherited in Zimbabwe for years prior to independence. This was another colleague who I worked with, less known than Dr. Julian Tudor Hart. His name's David Saunders, and he wrote many publications about primary health care. And in one of those publications, The Struggle for Health, he said healthcare workers should expand their work beyond medical care and address the social determinants of health and issues of social justice. And he also emphasized the importance of primary health care, which I think we would all now echo. But at the time, in the 70s and 80s, wasn't such a well-recognized concept. So working as a pediatrician, what we were seeing was huge amounts of malnutrition and diarrhea and children dying. The weaning diet there in Zimbabwe at that time was a water-based porridge based on sadza, which meant that there was very little nutrition for children being weaned. We're also seeing large amounts of vaccine-preventable diseases. So what did we do? This is, if you like, the first time I experienced appropriate technology. So we recommended adding high-energy protein-rich, locally available groundnut oil to the sadza. We took the common orange, that was probably the only orange squash bottle that was available then in Zimbabwe, and we added water, sugar, and salt in specified quantities, which stopped a lot of dehydration and deaths from diarrhea, and widespread vaccination campaigns made a huge difference. But then Faisal and I went from there into South Africa in the 1980s, where really South Africa was a place on fire. The youth were revolting in the townships. There was a lot of deaths and assassinations. And this was a picture at a funeral of a colleague who I worked with, looking after detainees who had been tortured. And this is where I think the activism in health comes in. So at the beginning of the 80s in South Africa, an organization called NAMDA was established, the National Medical and Dental Association. It was an anti-apartheid structure. It had about 1,000 doctors and dentists working in it who were opposed to the apartheid state. We established, as I mentioned, a detainee support committee for detainees who've been tortured in detention. The first grant I ever got was to set up an emergency services group for youth in townships who were being shot, were being frightened and persecuted. And what we did was train them in emergency first aid, and we gave emergency equipment. We wrote a report to Amnesty International about what was happening. And I was involved in bringing an interdict against the then Minister of Law and Order to try and stop torture and detention, and we failed miserably. My interdict didn't work. But I was working then in Alexandra Township, and in fact in charge of the pediatric department. We had a 6-day war, and many things will teach you things in your life, but you can't really prepare for what happens when young people are being shot all around you. And as we see today, when people are frightened and when they're injured, they seek care and protection in health services. And during that 6-day war, we tried to shelter many of these young people who had been injured. But again, we didn't win that battle, and many of them were removed. But at the same time, in Alexandria, it was a very large township north of Johannesburg. We saw South Africa had seen its first case of HIV in 1982, and sort of a couple of years later, I think we thought, we couldn't test, but we thought we were seeing the first case of HIV in Alexandra. But what we were seeing definitely were vaccine-preventable diseases. We still had polio, and we had a huge measles outbreak. And my first publication was from a household survey done in Alex, which was looking at reasons why children were not being immunized and why we were seeing these outbreaks. And what we now know is that one of the biggest determinants of whether children were going to be immunized was maternal education. So moving on, and so one of the things that you have to think about is how do you jump from clinical to research and then into policy? And in fact, it was an extraordinary time, because at the end of the 80s and the beginning of the 90s, South Africa was looking towards a new country. And so we were putting together a health policy. And that health policy included women's health, child health, and HIV, and I was involved in developing all of those. And this was the meeting that was held in Maputo in 1989 between the external wing, the people in exile from the health desk of the African National Congress, and those of us working inside the country against apartheid. And then, of course, we had the democracy, Nelson Mandela, and I was asked to set up what was then called RHIU, which was a research institute, to address the neglect that had occurred. Research was not being undertaken very much on the majority of people in South Africa. And so I was asked to say, would I set up what was then very much focusing on reproductive health and rapidly on HIV. But to go back to social justice, the other thing that occurred, which was very important in terms of thinking about public health and social justice, is we had a Truth and Reconciliation Commission. Faisal was one of the Truth Commissioners, and we had an entire part of the Truth Commission dedicated to what had happened in terms of abuses around health during apartheid. But let me then go on to HIV. So if you look at the maps on the left, in the top left-hand corner, you can see in 1984, this was the density of HIV infection in the Africa region. And if you go down to the slide on the bottom right, you can see in 1999 that Southern and East Africa had become the epicenter. We undertook the first big national household survey in the entire country, and we sampled children, young people rather, aged 15 to 24, and we looked at their HIV status and what their sexual behavior was. And for the first time, we showed this extraordinary increase. If you look at the purple bars, those are young women. And we saw between the ages of 17 and 18 up to the age of 21 that we went shooting up to a third of young women being infected with HIV. But at the same time as this was happening, we also moved into an era of AIDS denialism. President Thabo Mbeki, the then president, and the late Dr. Mantu Shabalala Msimang, the health minister, just argued that HIV didn't cause AIDS. And as a result, they didn't want to have antiretrovirals in the country. But this was at a time when mother-to-child transmission was rife. We had no antiretrovirals, and a third of pregnant women were HIV positive. At that time, myself, and in fact, Precious Matsotso, who's here, we were both appointed to what was called the Medicines Control Council then. That was the Drug Regulatory Authority. And if you look at this photo, you can probably pick out Precious, and you can probably pick out me. And we went on from there to become, Precious became the Registrar of Medicines, and I ended up chairing this council. But we had huge pressure not to register antiretrovirals, but we did. We registered nevirapine for mother-to-child transmission, and we registered other antiretrovirals as well. And that was in the face of huge political pressure that we should not do this. Time ticked on, and I now chair the Drug Regulatory Authority. But during COVID, it was the same experience, that there were all sorts of different interests, commercial, lobbyists, etc., who didn't or did want particular products. And what that really has taught me in terms of governance is that the importance of independent medicines regulation. That in fact you cannot be influenced by anybody, and you have to look at safety, quality and efficacy, because your job is to protect the public. So back to HIV and my institute. So we then said, well, we need to deliver services. The pressure was huge, as you can imagine, with so many young people infected. On the slides on the left-hand side, one of the earliest services we established was for sex workers. You can see that hotel at the bottom. These were brothels, and we had both outreach and clinic services for sex workers, where the rates of HIV infection were 60% plus. We also then moved through PEPFAR into providing support to government services in the middle pictures, but we also got grants to give services for HIV and TB to key populations, so MSM, transgender, and sex workers, but also to neglected populations at the bottom, people who will not otherwise access services. And those interventions have made, not just mine, but the national interventions made a huge difference over time to the HIV epidemic in South Africa. But importantly, we also had a huge program that focused on youth. This was called Love Life. We had interventions in all the provinces. We have 9 provinces. We had adolescent-friendly services, and when pre-exposure prophylaxis became available, we introduced it across the country into schools. But side by side with that, you then have to say, well, what is the research agenda? And this is more from the clinical research side. And we looked at pre-exposure prophylaxis. We were also looking at vaccines. That's proved much harder, but pre-exposure prophylaxis has really progressed. We needed to get the right drug into the right place and at the right time. And we started off looking at condoms, and I put a female condom there because we did a unique study, never to be repeated, where we kept washing condoms because sex workers told us they're very robust. We can reuse them, but we didn't know if it was safe. So we did studies where we had washing lines with female condoms along them, washed once, washed twice, washed 3 times, and we tested them. They were very robust, but we couldn't persuade WHO to approve a reusable condom. But we then also looked at topical microbicides, we're really focusing on young women, and we looked at gels and rings and films. Huge studies that we undertook, regional studies that were led by myself and my institute. Unfortunately, we were unsuccessful. What was much more successful were oral antiretrovirals, which proved to be partially effective. But a daily pill is a hard thing to take. So what has been really, really successful are the long-acting injectables. Long-acting cabotegravir, also led by a colleague in my institute, and lenacapavir, which is the latest product, which is a twice-yearly injectable. And we did acceptability studies, and people said, actually, we prefer to have an injection, something 2 monthly, something twice yearly. Thank you, we'll take that. So that's the good news. But the bad news is you then have to create access, which is the next step in getting products out. Long-acting cabotegravir is still not widely available, and when we looked at the costing, one of the reasons for South Africa is that it would have added 40% to the existing HIV health program, so it's not widely available. Lenacapavir is currently undergoing regulatory approval in many countries, including South Africa, and it looks like it's going to be more cost-effective than the long-acting cabotegravir because it's twice-yearly injection, and we think that adherence is likely to be greater. And if you look at the bottom, I'm sorry that the lines have jumped here on this presentation, but it is much cheaper per HIV infection, potentially in terms of cost-effectiveness. The reason for looking at this is that there are so many steps that you have to go through before you can actually finally introduce a product. And this is a good example of the complexity of this. Just going to put one slide in on another approach, which is very important before you introduce products. And in parallel to HIV, we were doing a lot of work on other sexually transmitted infections and other infectious diseases. But I just used HPV vaccines as an example, because here we did a whole series of studies, starting with piloting the introduction of HPV vaccines into schools, where we looked at the feasibility. Remember the EPI programs for the sort of under 2s, under 5s, never introduced vaccines into schools before. Is it feasible? Is it acceptable? What do you communicate to the parents and to the teachers, and will there be demand? Side by side with that, and I'll come back to this, I was then working with various technical advisory groups on vaccines. The national technical advisory groups called NITAG, the regional technical advisory group, these are all WHO structures, called the RITAG, and SAGE, which I'll talk about just now. But beyond that, we still saw that it was difficult. It's a 2-dose schedule. So we then developed a whole set of studies that looked at, can you give a single dose of this vaccine? It would free it from schools. It would mean that a single dose you can give widely and quickly. And we were able to show that a single dose in our populations was effective. And we also then looked at impact studies to demonstrate whether giving a single dose at a population level actually reduced HPV 16 and 18, which is what the vaccine is designed to do. And we were able to show that, including in young women living with HIV. So let me go on to global governance and vaccines. So in 2001, my clock is going backwards and forwards here, I chaired the first HIV vaccine consultation for WHO, and in 2005 I chaired a consultation on HPV vaccines. And as a result of that, I was invited to serve on the strategic advisory group of experts on immunization, and Joachim is here, I saw him here, who actually facilitates that committee today. It has become one of the most effective WHO committees. And if ever we wondered about what WHO's role is, I think just take this as a case study. It is hugely effective. It makes recommendations about new vaccines. It looks at schedules of old vaccines and continues to look. And it makes widespread recommendations that take everything from cost effectiveness to programs into account. I also work with the Regional Immunization Technical Advisory Group, also a WHO structure, which takes a SAGE recommendation and regionalizes it, because each region, as you can imagine, is different. And because I was working in this field, I've had the privilege to work with a number of international organizations listed here for polio, International AIDS Vaccine, Coalition for Epidemic Preparedness, Gavi, the Vaccine Alliance, IVI, and we'll hear from Jerome Kim later, and NIH and NIAID. But my breadth of work has then expanded with my institute to this list here. And you can see much wider vaccine-preventable diseases, and spanning anything from the research, the clinical research, the epidemiology, through to the policy that's required. And at the bottom, you can see that there's COVID, extensive work there, Mpox, pox viruses, Ebola. And that brings me on to the issue of emergencies. And WHO has a unique role to play for emergencies. As you're all familiar, that there are the International Health Regulations of 2005. And after the Ebola outbreak in West Africa in 2014, there was a whole question raised about whether these are still fit for purpose. And I was on a committee that reviewed these regulations. At the time, we said they probably need modification. But everyone was too nervous at that time to take that step to actually change them, because we were worried that we didn't want to lose what we had in the IHR. As a result of that, I worked with the Polio Emergency Committee and the COVID Emergency Committee. And moving on to today, I'm working now with regional and national committees on Mpox. In South Africa, we have an incident management team because we have an Mpox outbreak. Africa CDC has an emergency committee, and we declared the first public health emergency of continental security for the African region for Mpox. And there is a new initiative from WHO looking at pathogen families that are a threat for future pandemics. And I'm involved with the pox virus initiative there. And that's all very good, but if you haven't got the money, it's a problem. So 2 other things I'm just going to refer to is the two organizations who are part of this incredibly important global health infrastructure that I've had the honor to work with. Gavi is one, that's the Vaccine Alliance. It's estimated that Gavi will have avoided nearly 19 million future deaths between 2000 and 2023 because of its innovation. Many of you here are familiar with Gavi, but Gavi basically subsidizes for the poorest countries vaccines and gives support for health services to support the introduction of those vaccines. It also has vaccine stockpiles for emergencies for things such as Ebola and yellow fever, and most recently is also offering support for African vaccine manufacturing, which was a huge demand from the African region after COVID. Away from vaccines onto a broader health product initiative is called MedAccess, which I also work with. And here there is an initiative that says there are many products that are needed by low and middle income countries, but they're not going to get them because there isn't a high income country marketplace, whether it's new generation of malaria bed nets or whether it's multi-drug resistant TB drugs. And so again, MedAccess does volume guarantees, does market shaping, and creates an innovative financing offer that supports companies to actually become producers of these products that are needed in other parts of the world. So I've learned a lot of lessons. It's not quick learning these lessons. It's taken quite a long time. And really, there were sort of 10. 10 is always a good number. So it is really about identifying the problem, prioritizing a research agenda, and then looking for appropriate technology. Then looking at implementation science, policy, governance, finance, access, and community and trust. I've learned that, but let's just think where we are now. And here we have now devastating funding cuts that none of us were expecting, with huge implications. What we've had is sudden withdrawal. I think we would all understand and accept that countries absolutely have the autonomy, but the sudden withdrawal has caused huge pain. If you look at that graph at the top, you can see how important US funding has been for global health and global aid financing generally. And the US provided, of that amount, the US provided 30% of that was for global health. But equally, underneath, many European countries are bilateral donors, philanthropic organizations such as the Gates Foundation. That money is now under threat. So we are really facing a new era where we're going to have to think what we do. Replenishment targets are coming up this year for WHO, for Global Fund, for Gavi, for the Pandemic Fund. 100 billion is what we're looking for at a time where we're seeing these cuts. And we have now seen also huge cuts in research, in the R&D, particularly from NIH, that was responsible for half the global R&D research funding. So now, we should look past these events of today and into the possibilities of tomorrow. And as we do this, we shouldn't say, let's have faster horses. We actually need to look at a new model, which in this case was the automobile. And we need to rethink global health. And as we rethink global health in the context of all of these challenges that we're looking at, what should we be looking at? Well, we need to look at global governance, financing, health services, research, and leapfrogging technology. So global governance is currently being looked at, and the World Health Assembly has obviously been discussing this, but really to look at the roles and responsibilities of who does what. So who does what the best? Who should lead in what? What in particular is WHO's role, power, norms and standards, emergencies? WHO has a critical role to play. How do we strengthen that? But we need to streamline all of the global structures and funding, because clearly what we've been funding is not sustainable. There should be a strengthened, many people are arguing, and I would agree, a strengthened regional focus. We should be responsive to country needs, but especially the lowest income countries. We are going to have to prioritize. We can no longer do everything. And we're going to have to start to use, particularly in the low middle income countries, local versus global expertise. So if we're going to make the case for funding, how do we do this? This map shows the amount of foreign aid that's received as a share of national income. And the darker the green, the bigger the amount of foreign aid that's been received. But in this map as well, just note the comment at the bottom, over 50% of low-income countries are now at high risk of debt crisis. So how do we make the case for continued financing for global health? Well, first of all, I would say there's high returns on social investment. Immunization, maternal child health, incredibly high returns in terms of social development. There are many international benefits by funding global health goods, funding pandemic prevention, preventing the expansion of HIV in the African region. Remember, we've had a withdrawal of the PEPFAR program. If we have expansion of HIV in the African region, we are going to create a huge reservoir of immunocompromised individuals. And if we want to see emergence of new pathogens, that's exactly what you could do. So we have to also think, how do we stop that from happening? And we have to think again and in a different way about sources of funding. Richer countries, I would argue, should, for the reasons I've given above, continue with the ODA to give support to poorer countries. But countries, and you've heard this loudly from the African region, countries also need to look to themselves. Budgets need to be redirected for their own health services, but debt relief needs to come into this, noting what I've said there about over 50% of low-income countries are at risk of a debt crisis. Clever taxation, the sin taxes, the tobacco, sugar taxes can also be considered. But the development banks and multilateral organizations also need to rethink what is their model. Innovative financing such as Gavi and MedAccess can be expanded. Bilateral aid should continue, I would argue, for the poorest countries from rich countries. And philanthropy remains incredibly important. We also need to make the case for financing of research and development. And to start with that box on the right, this is just one example, that the return on investment for $1 invested for neglected diseases for R&D is $405. So you can make the case on an economic basis. And you can say to countries, but actually R&D is critical for your development, it's critical for your growth. You need to find solutions for your state, for your society. Culturally, reputationally, this is a good thing for a country to do, and the return on investment. But for global investment, we still need to make that case. And I would say that one of the ways to make that case is to say, well, you're contributing to global development, which makes everyone safe. That there are shared global benefits, such as pandemic research, and that actually, if we all work together, we will accelerate technology development. And then there's the feel-good factor. I think George Bush was hugely proud, as he should have been, about initiating PEPFAR. There is a feel-good factor for rich countries to be able to assist. We need to look at the other end of things, because we can't just consume and consume. So we need to improve health systems. We need to go from the bottom up instead of the top down and have country-driven priorities, patient-centered services, integration of services, HIV and chronic diseases, they now go together. We need to redesign, we need new tools for self-care and management. We need to get patients out of the clinics, because the clinics are overcrowded and under-resourced. Give people tools that they can manage some of their own diseases, even in low-resource settings. We must redesign health products for ease of use and delivery, and I'm going back to lenacapavir. Twice-a-year injection is much easier than people coming every month to get tablets to take every day. Cross-border sharing and surveillance is absolutely critical if we're going to consider outbreaks and pandemics. And then we need to leapfrog technology, and particularly improve connectivity, electricity, and artificial intelligence. So leapfrogging technology, there's been a lot of discussion at this World Health Assembly. This is going to be cost-saving. Every model you'll see with leapfrogging technology using AI for health shows cost savings. You increase health worker competency. You can do it remotely. You increase the accuracy of patient diagnosis. You can therefore have early detection and surveillance and response to outbreaks at a much earlier stage. If you digitalize everything from a facility to a district to a national level, you get incredible data sets that will help you respond to what your problems are. And you can respond to patients' needs. And we're already using chatbots in languages so that people can ask their own questions and really understand what it is that they need. And you improve self-care. And finally, as we rethink this, I would also argue that we need to rethink community engagement. I think that we've become complacent about this. On every proposal you write where you're doing funding, you talk about community engagement as the last tick box, but do we really know what we think? We need a new vision for community engagement in this current context. And we need to reconsider, I would say, the activism model. It can't only be oppositional. I think now we've matured, and it must be driven by communities, but it must also be done in partnership with health services, with ministries of health, and with the private sector. We can do things together, we can oppose when we need to, but we do need to also rethink that model. And, very important, we need to create a much better understanding of science literacy to build trust in science, but trust in medicine, which has been eroded during COVID, vaccines in particular, and we have to counter misinformation and disinformation. And this diagram on the right is from Nature from this year, which indicates that a large multi-country survey, still people trust scientists, about 2/3, but people more likely to go to family and friends for guidance. So we need to think, who are the messengers that we want to get these messages out so that we can actually rebuild that trust? So finally, let me leave you with this quote from Nelson Mandela, and it's a quote for today. "Do not judge me by my successes. Judge me by how many times I fell down and got back up again." I want to thank so many people that I spoke to. I told you I was neurotic about giving this talk. It's a very difficult talk to give because you're reflecting on yourself. So I spoke to lots and lots of wonderful people and asked them, what is your view of where we are today? And got incredible feedback. And I'd like to thank everyone who's listed here. I'd like to thank very much the honor from the Korean government and the foundation for awarding me this prize. I'd like to thank all the participants. I've done lots of research over the years. I've got many colleagues I can see in the audience who I'd also like to thank, who are not only colleagues but friends, but have taught me such a lot. The donors who I've listed have been hugely important, and we should never forget that. And even if they're reduced or gone now, I want to say thank you for what they've given us. And the many colleagues who are continuing the struggle for global health. And finally, I want to thank this lot, who is my family. I've got extra extended family here, but this is my family here, who have been incredibly supportive to me in my career and tolerated, as Precious said, my long stays in airports. Thank you very much.